I'm Dr. Marla Shapiro, and I'm on the Board of Trustees of the International Menopause Society. And I'm pleased to be joined today by Dr. Rossella Nappi. She is Professor of Obstetrics and Gynecology at the University of Pavia, Italy, Director of Gynecological Endocrinology, IVF and Menopause Research Center. And for many of us at IMS, she has been a fixture. She is presently the General Secretary of IMS, and we always turn to her for information and education. Welcome, Rossella. It's lovely to see you.
Hi, Marla. It's a pleasure to be with you.
So, we're going to talk about a topic that somehow we need to keep on talking about because we know that women are not being diagnosed and treated. So, for our healthcare professionals out there, I would like you first to talk about VVA and GSM and where VVA falls into GSM. What are these letters? What do they stand for? And what do we need to know?
VVA, vulvovaginal atrophy, is a condition we know since many, many years. And recently, in 2014, a group of experts convened in Chicago, and they decided that this word was a bit outdated, but especially they realized that it's very difficult to speak aloud the vagina, even in the office of the OBGYN or the medical practitioner. And especially, you can imagine, in the press or on TV show. So for this reason, they decided that we should use a word that was uh, more sensible, and therefore they select the genitourinary syndrome of menopause. But also they did that because they want to put the attention on the fact that this is a syndrome. It's a condition that has many symptoms, not only related to the vagina or the vulva, but broadly distributed in the pelvic floor, the urinary system, and so on.
But vulvovaginal atrophy, and one can understand nobody likes the word atrophy. Many women often don't bring it up to their healthcare practitioners. So, what would you advise healthcare practitioners to be thinking about in terms of when they're likely to see it in relationship to the menopause?
I agree. Women they don't like the word atrophy because it's something negative, and doctors should be proactive in order to bring up the subject in the consultation. First of all, they should ask in a very sensible way. Many women suffer from, for example, from vaginal dryness, pain with intercourse, burning, itching, even during sport activity or other aspects of your daily life. This is happening to you as well. This is the first question to break the ice with your patient. Second, of course, if you are in an OBGYN consultation, you have some objective sign that you may record on the chart of the patient, and you will see the lining of the vagina is pale. You may observe that the vaginal canal is unelastic, and so you can record all these different issues and try to motivate the patient to be proactive on the condition, because many women they believe it's just a question of aging, and they do not understand that there is a clear connection with the endocrine changes that we observe in the vagina and in the genital in general. It's both the lack of estrogen, and of course we have also to take into account the aging phenomena, and this aging phenomena is really concomitant to the estrogen deficiency. But if we do not reverse at least the estrogen deficiency, the condition related to aging will progress, will become chronic, and at some point it will become even irreversible.
So let's talk about something that we often don't think about, which is the impact that it has. I mean, obviously, painful sexual intercourse and vaginal discharge a woman may come in complaining about, but what is the impact in terms of we think about this gender disease being in women, but in fact, the impact is not necessarily for the women alone.
Exactly. The impact is on the woman, of course, because she feel a vaginal dryness, she feel sexual pain. We know that more or less 50% of women report these symptoms in survey. And even more when you go to study in menopause clinic, up to 90% of women. And the impact is on the relationship, first of all. So on the intimacy of the couple, we have seen that when vaginal atrophy is there, there is an impact not only on quality of life of women, but really on the quality of the relationship, not only from a sexual point of view, but also on intimacy. So it's a great burden that doctors really need to do something to help women in this with this condition.
So, is looking at the vaginal vault enough? Is looking at the introitus enough? Is there anything more that we need to do to make the diagnosis? And I bring this up because, in North America and other countries, we're only doing pap smears every 3 years, and people aren't necessarily taking a look at the rest.
You are absolutely right. Pap smear is not enough. First of all, of course, we interview the patient, but then we really need to describe carefully what we've seen. And it's the vagina is not only the vagina, we have the vulva, so we have to look at the introitus. We now develop some scales to rate the symptoms and to describe where the pain, for example, is located, because we have to keep in mind that vaginal atrophy is very common, but as physician, we should rule out also other conditions that are less common that may be related also to vaginal atrophy. Let think about lichen sclerosis, for example.
Mhm.
So we really need to be precise in the description. We have to consider the comorbidity, for example, women having recurrent infection, vaginal infection. So it's very important to measure pH, for example, a very easy tool to measure the amount of estrogenization within the vagina. We know that the microbiota is changing with the estrogen deficiency. So we have to rule out infection, of course, but we have to keep in mind that vulvovaginal atrophy sometimes is associated to atrophic vaginitis, so to Gardnerella and other bacteria from the gut reservoir, such as E. coli, that can also give you cystitis and urinary symptoms in general. So we really need to rate this symptom and to try to figure out what is the best solution for the patient you have in front of you.
Okay, so let's move on to treatment. And let's talk about when should treatment be initiated and the types of treatment that are available for women across the globe.
We have discovered throughout the years that it's very important to be proactive in terms of treatment. So we don't have to wait too long to treat the VVA. We realize that we treat VVA only when the condition is very severe. And so we really need to start early in the menopausal trajectory. If we break the ice with our patient and we realize that they have vaginal atrophy, or at least some symptoms, let's say vaginal dryness, which is the most common, first line treatment should be lubricants and moisturizers. They provide relief from pain during sexual intercourse, but they help the structure also the vaginal mucosa. Then we have to consider local estrogen therapy, because they are effective strategies, especially when lubricants and moisturizers are not enough or the symptom become more clinically relevant. And we have to keep in mind that low dose estrogen products we have on the market, they are both efficacious and with a good safety profile. Then we have also to keep in mind that for some women, the one they suffer from climateric symptoms, especially moderate and severe hot flashes, and they are in need of prevention for osteoporosis, even systemic hormone therapy can relieve VVA. But this is only when VVA is part of the climateric syndrome. And last but not least, I would like to spend a word on the fact that different markets, they have different products, and we have always to rely on the product we have across the world in our market, the one we are more familiar with, the one we can propose to our patient, and we can and we don't have to use maybe strategies that are not evidence based. I'm alluding to the fact that there is an epidemic use, at least in some part of the world, of thermal energy, for example, device that can be useful in women with contraindication, for example, to hormone therapy. But we really need to be careful that not every woman should use this technique. And we are still in the process to produce clear cut guidelines in order to establish an algorithm that allow us to propose this treatment to women. And this is the only way to really produce good evidence-based medicine and care to women.
And before I let you go, a word on the chronicity of treatment. That, for many women who have hot flashes and night sweats, they will be treated, but for many women, they'll go away over a 6 year period or so. Some women will never lose their hot flashes, but most women will. And then they stop their treatment. This is a chronic, progressive, estrogen deficient condition. How long do we treat it?
We should treat how long is needed, in my opinion. And since this is a chronic condition, we should explain very well to our patient that adherence to the treatment is essential. And this is the only way the treatment is really effective, because we can reverse the condition when it's not so severe, and we can obtain a lot of benefit. However, we know that women sometimes they don't like to put this product in the vagina. We should really explain them that this is relevant for their quality of life and well-being, that the symptoms will not disappear. There are some women, they are also lucky because they have on the market product that can be used orally. And in this case, we have, for example, in our market in Italy, where I come from, ospemifen, which is a SERM, but for this drug, we don't have so much long-term data because they are new on the market. Whereas, for example, for local estrogen therapy, we have plenty of data suggesting that we can use as long as needed. Of course, we really need to check the woman annually in order to rule out, for example, the possibility that some side effects may occur, because the data we have from a clinical study, they are usually up to 52 weeks of observation. But for us in practice, what is important to suggest to the woman is really to go on with the treatment, and then maybe we can revise in 1 year and see if the treat is still needed at that dose with that kind of drug, and we can also exchange treatment depending on the need of the woman.
And my last question, I promise, before I let you go, is that in many markets, we're seeing the emergence of laser therapy. Any words about the use of laser?
Laser, we have some experience in Italy because Italians, they have used a lot. And on the short term, laser can be effective. We have different kind of laser. We have CO2 laser, we have erbium laser, we have also other kind of thermal energy, such as radio frequency. They are coming out. This treatment, they have the benefit of being not pharmacologically, but we don't have many long-term studies. So we really need to wait and be cautious to think about that. We don't know, for example, how long the benefit will last. We have data just up to 1 2 years, and it's not for everybody because unfortunately, at least in my country, they are not reimbursed this kind of treatment for the national health system. And since VVA is an epidemic condition, as a physician and a researcher, I always prefer to propose to my patient what is really evidence based and is affordable for the majority of people. But of course, for example, for women, they are breast cancer survivor. For women, they have contraindication to use hormone therapy. These strategies, they are extremely relevant, and we hope that we will have more data out there to prove their effectiveness and even safety on the long term.
Well, thank you so much for joining me today.
Thank you, Marla, for giving me the opportunity to be here.